Hello, good morning everyone, and welcome to our ENDO 2024 Pediatric Health News Conference. We're so happy that everyone can make it to Boston today. My name is Colleen Williams, and I'm the Senior Manager of Communications here at the Endocrine Society. And today's news conference will explore the latest in pediatric health research. We're super pleased to have with us today Dr. Alexandra Donovan of Charles Drew University of Medicine and Science in Los Angeles, California, Dr. Andrew Abaje of the University of Eastern Finland, and Dr. Gabriel Castaño of Texas Children's Hospital, Baylor College of Medicine in Houston, Texas. Over the next 30 minutes, each speaker will present their findings, and then we will end the session with a Q&A. Please note that this conference is being live streamed, and many journalists are joining us remotely today. Because we're live streaming, it's important for all remarks to be made into a microphone to enable those who are joining us virtually to be able to hear what is being said in the room. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and we'll address those during the Q&A. I would now like to invite our first presenter, Dr. Donovan, to speak.
Good morning. Thank you for having me. Colleen, I'm just going to put this into presenter mode here. All right, today I'm here to speak with you on early life stress and pubertal predictors of early substance use, sex differences, and substance-specific relationships. Early life stress, referred to here as ELS, is a construct comprising children's experiences of abuse, neglect, and family conflict, as well as societal and community stressors, such as racial or ethnic discrimination, low socioeconomic status, and neighborhood violence. These experiences can have long-lasting impacts on health, increasing the risk of heart disease, depression, and substance use disorders. But how do these early life experiences leave their lasting impacts? Studies have theorized that effects of early life stress impact the hypothalamic pituitary gonadal axis, which interacts with the hypothalamic pituitary adrenal, or HPA, axis. Adolescent neurodevelopment depends on proper function of both axes, and dysregulation of these axes can hamper the developing cognitive, limbic, and reward systems. Previous literature has indicated this process may be more sensitive among females than males. Here, the early life stressor of parental depression is impacting the ability of the HPA axis to respond to a stress test, but we only see this effect among females. Though some studies have begun probing the portions of these connections, there are still questions to be answered. Some have examined substance use patterns, others the effects of traumatic events, and still others the combination of community and family influences. Our study examined early life stressors during adolescence with the data available in the Adolescent Brain Cognitive Development Study, or ABCD. This multi-site, multi-wave national study has accumulated data allowing us to start from the beginning, looking at the time to first use of substances. The benefit of the longitudinal design of ABCD will be that we can continuously build on findings. Our study assessed ELS measures and covariates at baseline, developing a snapshot of our participants who were substance naive. These measures were comprised of both parent and youth reports on available resources, family-related stressors, and traumatic events. Our analysis looked at overall effects across combined male and female samples, and effects within sex by splitting into male and female samples separately. Our outcome measure was the time to first use of a substance, defined as either a full drink of alcohol or more than a puff or taste of nicotine or marijuana. The data from the ABCD population included a realistic proportion of minorities, often underrepresented in research, in an effort to best reflect the general population. And here is what we found. Higher early life stress is associated with increased risk of first substance use across both male and female samples. This appears to be driven by family stress measures. As we can see, ELS family in this picture here is significant. This tracks with existing literature citing parental psychopathology as a significant risk factor for adolescent mental health issues, including substance use. Overall, we can see more significant risk factors, we can see more significant risk factors present among females than males as soon as I get back to that slide. For example, ELS environmental is significant within the female sample but not the male sample. These environmental stressors are related to available resources and socioeconomic status. In low-resource environments, some studies have found females undergo puberty earlier, and early puberty has been found to increase the risk of early substance use. Though we also looked at alcohol and marijuana individually, I have limited time here, and so I'd like to discuss our findings for nicotine. Again, we can see that the overall ELS, referred as ELS total, and ELS family are significant risk factors for both sexes. And we can see the ELS environmental factor here significant for females again. However, males now display an association between ELS trauma scores and increased risk of first nicotine use. It's surprising that females do not show any association between trauma and use, as male and female scores across this measure were not significantly different. This suggests there is another factor at play in the male sample that is not yet captured here, potentially peer influences or the beginnings of other mental health disorders such as externalizing disorders, of which the symptoms include increased substance use. In summary, we found that ELS total is associated with increased risk of first substance use within both sexes, potentially driven by family measures. In addition to family associations, females displayed an association with environmental scores and increased risk of first use, while males displayed an association with traumatic event scores and nicotine use. After adjusting for sampling and baseline use, salivary hormone levels that we looked at, DHEA, testosterone, estradiol, were no longer a significant predictor of first substance use. Although they did not mediate the effect of ELS on time to use, when we examined the female sample, testosterone and estradiol levels were significant predictors of alcohol and nicotine use in general. This suggests that family-based intervention and preventative measures would be highly efficacious, and many of the existing prevention and intervention programs focus on family involvement and family issues. Though sex did not moderate the association between sex did moderate the association between ELS and first use of substances. Our study did have some limitations. Because of the young age of the sample, ages 9 to 10, substance use was only present in 4.3%. We did not assess any prenatal or genetic effects that are likely present. We also did not assess the impact of peer attitudes on substance use. And finally, we did a simple main effects assessment. In the future, our studies hope to include more longitudinal measures of salivary hormones, as well as track the progression of puberty and the interaction of these ELS measures with progressing increases in substance use. I have no disclosures to announce, and I'd like to thank my mentorship group here at Charles R. Drew University of Medicine and Science in Los Angeles, California, and would be happy to take any questions. Thank you.
All right, thank you so much, Dr. Donovan. I would now like to invite Dr. Abaje to present. Let me just pull it up here.
Thank you very much for the opportunity to speak about sedentariness and physical activity and liver disease in kids. I have nothing to disclose. in summary, the study I'm going to present found that in kids about the age of 11 years, they spend 6 hours per day sedentary, which increased to about 9 hours per day by young adulthood. And that consequence of increase in sedentary time was an increase in the risks for severe liver steatosis and liver cirrhosis. On the other hand, light physical activity reversed the consequence of sedentariness. But unfortunately, light physical activity was about 6 hours per day when they were in childhood, and by young adulthood it reduced to 3 hours per day. But even though we have 3 hours per day in young adulthood, it was still sufficient to reverse the effect of sedentariness. And so every additional 30 minutes of light physical activity decreased the risk of liver steatosis and liver cirrhosis by minus 33%. We have a background to this story, and it's that the World Health Organization in 2020 presented a physical activity guideline. Alongside that guideline, there was also the recommended research gaps that made that physical activity guideline a little bit limited. And then there were these questions about what we need to do in the future to improve the physical activity guideline subsequently. So there was a specific recommendation for kids from the age of 5 to the age of 17. They wanted to see evidence regarding sedentary behavior and health outcomes in this age group, and as well as, if possible, there should be an adequately powered studies, observational studies, long-term studies that can last a long time, which clinical trial cannot afford, and also how independent sedentary time and physical activity may impact health outcomes in children. So the new guideline, that's the latest current guideline of the World Health Organization, do not also have any evidence on light physical activity, and so there was no recommendation. So in that regard, we began to analyze field data, a particular data, and then in the past 1 year, we've published a few papers. So this paper was published in Nature Communication, where we saw that sedentariness in childhood was almost an independent causal risk factor for excessive fat increase or fat mass obesity. We also showed that sedentariness from childhood is also a causal risk factor for hyperlipidemia. And interestingly, light physical activity reversed all those adverse effects of sedentariness. We also noted that in another study published in the Journal of Clinical Endocrinology and Metabolism, we also noted that sedentariness is also an independent risk factor for an increase in inflammation in the young population. And recently, I think in March, we published where sedentariness was a causal risk factor for vascular damage, premature vascular damage in this population. And just 3 or 4 weeks ago, we published in the European Journal of Preventive Cardiology, where we showed that sedentariness is also a causal risk factor for premature cardiac damage. It contributes about 40% to the total increase in cardiac mass between the age of 17 and 24 years, which makes sedentariness a very important factor in disease causation. However, what is the role of sedentariness in liver? And that's the essence of this study today. So we know that the nomenclature appears to have changed in the past few months. We now have what we describe as metabolic dysfunction-associated steatosis liver disease, MASLD for short, removing non-alcoholic status because of stigma and things like that. These are risk factors, as well as liver cirrhosis, are risk factor for liver cancer and liver transplant. So in 2016, there was a study that showed that sedentariness in childhood, physical activity reduced the risk of liver fat at the age of 17 years. However, there was no measure of sedentariness. There was also no measure of light physical activity in that age group. A recent study published in JAMA amongst adults who had self-reported physical activity also showed that engaging in vigorous physical activity measured with questionnaire was associated with a reduction in liver fat assessed at the age of 50. So yet, we still have this adequately powered observational study that will show us the relationship between sedentariness, light physical activity, and liver outcome still missing. up to now, and thankfully we have this study. So hence the aim of the study to look at the longitudinal association between sedentary time and physical activity and liver outcomes, and also to see if liver enzymes are also implicated, apart from measuring with an ultrasound scan or a transient elastography. And then we will need to find out if there's an explanation to the contribution of sedentary time to liver damage. So we have this study, the Children of the 90s study, or the ASPAC study for short, Alvon longitudinal study of parent and children in the UK. It's a longitudinal birth cohort where children, almost 14,000 of them, have been followed up for nearly 30 years. But for those that had the DEXA scan at the age of 17 and at the age of 24 years, the liver scan were included in this study. So we have about 2,684 altogether. So we had different objective measurement, like objective measure of physical activity and objective measure of fat mass and so on and so forth. So to quantify the liver assessment, we have this threshold. The cut point for liver stiffness or liver fibrosis was based on this staging. So when a child or a young adult or an adolescent has an F4 staging of liver stiffness, that's a liver cirrhosis. And if there is an S3 staging of liver stiffness, or liver steatosis, then that is a severe form of liver steatosis, which means that 66% of liver fat concentration is in the liver. In that situation, that's quite severe. But at 17 years of age, it was only an abdominal scan and not transient elastography. And so we couldn't compare those two results. Of course, they can give us a summary of what is happening at the age of 17. So the results show that, as I said earlier in the summarized first slide, here we can see that progressively, as children grew, the time spent sedentary increased. And incidentally, at that same time, light physical activity dropped, while moderate to vigorous physical activity, which has been the focus of many of the guidelines, apparently remains about the same. And so, to correct the problem of sedentariness, moderate to vigorous physical activity is not the solution. It is light physical activity. Then we see, importantly, that the prevalence of liver fat or excess liver fat, liver steatosis, and advanced fibrosis is that at the age of 17, you have about just 1 in 40, 2.7% of kids having liver fat of about more than 5% in their liver, while at that same time, advanced fibrosis was 0.9%. Just 7 years later, the situation became alarming, such that the presence or the prevalence of liver steatosis in this population was 20.5, which is an 8 times increase in the prevalence, while the advanced liver fibrosis increased by 10%, so from 0.1 now to 3, sorry, from 0.9 to 3, so it increased threefold. But our main focus is the severe stage. Remember the staging I talked about, the F4 and the S3. In that staging, what do we see? That 10% of those at the age of 24 who already have excess liver fat had a severe stage, which means that we need to start looking at children and investigating how to correct for liver, identify liver problems as early as possible. And also, 10% of those who have advanced liver fibrosis already have liver cirrhosis, which is quite remarkable, clinically significant. And so our results show that during the course of this time, sedentary time, spending time sedentary is a causal risk factor for both severe liver steatosis and as well as liver cirrhosis. While light physical activity antagonizes that process, which is very remarkable. But moderate to vigorous physical activity has a good effect on reducing the risk for severe liver steatosis. At the same time, those liver enzymes were also increased by sedentariness and reduced by light physical activity and moderate vigorous physical activity. We found an explanation for this result, that sedentariness increased inflammation, and that drives the problem of liver damage in this young population to about 15%. We didn't find any relationship between triglyceride and insulin resistance in relationship between sedentariness and liver fat. And fat mass itself concealed the effect of sedentariness because there appears to be at the same level of predicting excess liver fat. So it's either sedentariness or fat mass, and as with about 30% of the effect of sedentary time was concealed by excess fat mass. And so this study is being simultaneously published this week in Nature's MPJ Gut and Liver, and you can browse and you can study more about the result. So lastly, as I said earlier, every 30 minutes increase beyond 6 hours per day spent sedentary increases the risk of primary liver or premature liver damage by about 15%. However, every 30 minutes increase in light physical activity reduces that risk by 33%, which is very remarkable. And so I thank those children who have continued to contribute to this study in the past 30 years, as well as all my collaborators. And I also especially thank the Endocrine Society. This is the March edition of Endocrine News magazine, and I was featured on the cover page. I need to fight for the kids, and I'm still here fighting for the kids. So let's keep on fighting for the kids, because kids today are adults tomorrow. And I also thank the European Association for the Study of Obesity, as well as in Novo Nordisk Foundation for giving me an award. I just came back from Venice, where I was given an award, about 300,000 Danish kroner, on childhood obesity. Thank you very much for listening.
Thank you so much for that wonderful presentation. I'm now going to invite Dr. Castagno to speak.
You're an excellent speaker.
Thank you. Yeah, I'm Gabriel Castagno, and I'm going to be talking about the real-world implications and limitation of GLP-1RA prescriptions in adolescents. So going quickly over the background. For adolescents, these medications have been approved in 2019 for type 2, for kids above 10, and for obesity in 2020 for kids above 12. Many of them go through a titration regimen specifically for liraglutide. They go in weekly intervals. For type 2, the goal is 1.8 milligrams, whereas for weight management is 3.0. Now, these medications, which is an incretin, have already shown a confer of beneficial metabolism functions, improving A1C, improving fat liver, heart disease. So they have a lot of benefits that have been shown in the adult populations. And since approved for adults, there have been some studies that are looking at these implications and limitations on that population, and really nothing has been done to see how is this affecting kids. So we decided to look into that, a little bit on the methodology. We did review patients under 18 who were prescribed GLP-1, and all this data was pulled from the EMR. Then we did get demographics, comorbidities, the active medication, and prescriptions. We also did a manual chart review to assess the insurance approval, as well as initiation days and treatment doses. And then for those who completed at least 6 months of treatment on liraglutide, we further collected dose titration, medication engagement, as well as side effects. We defined adequate medication engagement as those who miss less than 2 doses per week, which was recommended on the charts. And for titration, we consider adequate titration, which is important to know, if by their next follow-up visit that we're already at the treatment dose, which is already a slow titration because most of them will typically follow at 3 months. We then calculated percentage of insurance approvals as well as t-test analysis. Then diving into the results. We did have close to 600 patients, more type 2 diabetes, more females, more white and more Hispanics, but when doing all the analysis, seems like it was very well, there were no statistical differences. We did have more Medicaid patients, and the average treatment duration was about 14.5 months. Sorry about that typo. The mean age of treatment was close to 15 for the population. And the comorbidities, they range between 10% to 20%. The one that kind of stood out was dyslipidemia in the group of type 2 diabetes. Then going to the prescription outcomes. The majority of the medications were prescribed for liraglutide, which also makes sense since this one's the first one that was approved by the FDA. And as you can see the percentages there. And then the approval rates, going like from conditions, you can see that for weight management, there's very little approval from both Medicare and private, which seems a slight preference for private. As for type 2, it's a better covered 70-60% when you compare public versus private. This data in adults, in specifically type 2 patients, is closer to 85 to 90%. Then going to titration. As you can see, 50% have adequate titration by what we defined, and several of them did not reach the full treatment dose, which is more important for weight management outcomes. As you can see, 44% never got there. Then for the final treatment dose, specifically for liraglutide, as you can see, remember most of the patients that we had were liraglutide. Most of them stayed at the 1.8 with 72%, and a few of them just range between the 0.6 to all the way to 3.0, with only being around 1%. Now, about medication engagement. As you can see, we have about 50% that there was no documented medication engagement, but 44% in the weight management were reported to have good medication engagement, where only 20% in the type 2 population. And then from all the approved medications for GLP-1s, there's that 84 and 19 were those that either never started the medication for whatever reason despite being approved, and 84 patients just stopped the medication. We'll see why. But that ranges close to 40% of the patients that had already an insured approved medication and just never took the medication or stopped it. The most common reason for stopping the medication was GI side effects, which was described in the clinical trials as well. There were some that had hypoglycemia, some had A1C improvements, some did not feel the medication was efficacy, some reported expensive copays. And specifically for the ones at GI side effects, we did find 4 patients with pancreatitis and 2 of them with severe pancreatitis. Those that had the severe pancreatitis were in the type 2 group. So going to the main conclusions. GLP-1 coverage by insurance in pediatrics is under 70% for patients with type 2 and under 40% of those with obesity. 44% of the patients with obesity never reached the treatment dose. There may be a tendency for public insurance to have better coverage for patients with type 2 and private insurance for non-type 2. Few patients have adequate medication engagement. And the most common reason for stopping this medication were GI side effects, and we did find 2 cases of severe pancreatitis that have not been reported in the clinical trials. Yeah. Let me know if you have any questions. Thank you.
Okay, great. Thank you very much, Dr. Castaño. With that, we'll now begin the Q&A session. I'll turn it over to my colleague, Jenny, if we have any questions in the room or online as well.
I have a question for Dr. Castaño. I'm wondering if you could talk a little bit about, you found that, many patients didn't reach their treatment dose, and that the adherence to medication was not great. But I'm wondering, sort of, what does that tell us about how doctors can apply these findings to their clinical practice?
Yeah, that's a good question. So it's a retrospective chart review, so we do have some limitations as to know exactly who were compliant and how the titration was done. But having in mind that reminding the patients how to titrate up, because in the charts some might find that they were never told to do so, which I am pretty sure they were. So maybe more adequate follow-up and more frequent reminders about the increasing the titration. If they're not being able to titrate up, assess why. And as for the compliance, just reminding them that the medication only works if you take it. So a lot of people just remind them just to try to remember it like in the morning or in the night, have like a, because we don't have like the pill boxes for like the daily pill, but maybe having a daily alarm with like, take your GLP-1 or something. I don't know if that answers the questions.
Yeah, and I have one more. Just regarding the severe cases of pancreatitis, you said they weren't found in the clinical trials. I'm wondering are there any next steps you think should happen to explore this potential side effect more?
Well, this happens after once a medication is released to the public, they still have to report what the side effects are. This was just an association. It happened to be that those two patients had type 2, were on liraglutide. It led to stopping of the medication. Was this caused by the liraglutide? I don't know, but it's something that we need to keep an eye on as we continue to prescribe this and just make those associations.
Thanks.
Great, we have a few questions from the online audience. Jill Roulette with Endocrine Today for Dr. Donovan. She was asking, the Apple Women's Health Study just out reported more girls reaching puberty at younger ages. So the association you found could really matter. What do you think is the reason girls with earlier puberty initiate substance use at a young age, but the opposite for boys?
Just in reference to the first part of the question, the girls reaching early puberty face a few different factors. Certainly there may be it's certainly a mesh between biological and societal factors. Girls reaching puberty, often their bodies change very visibly, and so they can be treated differently. They have a tendency to, and this is, what studies have found, not generally speaking blanket about girls through puberty. However, there's a tendency for them to associate with older age groups, and so they may be around other kids who are older and more likely to be using substances. There's also the effect of mental health, that girls who reach earlier puberty in reference to their peers, earlier than their peers, they often have mental health issues. A lot of it is likely around body issues, around being different. And so struggling with those mental health issues, a lack of positive coping behaviors can often lead to adapting substance use as a coping mechanism instead, especially if they're associating with an older group who may be exploring with substances that their younger peers are not.
Great, thank you. Dr. Agabaje, I also have a question for you from Endocrine Today. Did you see a correlation between BMI and sedentariness and liver disease? That is, did the participants with worse liver metrics tend to have obesity as well as sedentary behavior?
So thank you for the question. So that informs the metabolic dysfunction-associated steatotic liver disease. That's a new definition. In that definition, anyone that has any of these kids that has at least one of those criteria for defining metabolic syndrome, as well as liver fat. So we try to avoid BMI in kids because BMI is a problematic tool in assessing obesity in kids because it does not delineate between fat mass and muscle mass, and also because it changes significantly with age and also with sex. So here in this study, we have a direct measure of fat mass. That's a dual energy X-ray absorptiometry. And that was what was used in this study. So I can speak on that because that's a better measure than BMI. So as I said in one of the slides, was that about 18 to 28% of the relationship between sedentariness and liver fat, severe liver steatosis, is concealed by excess or an increase in fat mass. And that provides more evidence than using BMI.
Great, thank you. Dr. Castaño, I have a question for you from Endocrine Today. Even among patients with insurance approvals for liraglutide, there was limited engagement with therapy. Is this level of engagement typical for pediatric patients or for patients with obesity, for example? Can you speculate why so many here never persisted with treatment at the optimal dosage?
This is just speculation, but part of that was not being able to verify. When we do look at the prescriptions for liraglutide, there's like the Saxenda for weight and the Victoza for type 2, which is 1.8 formulation. We do think that those that may not have reached more higher doses on the weight management was because maybe was not approved at the higher dose for the Saxenda. That's merely speculation, I don't know. And then what was the other part about the compliance?
She asked about, there was limited engagement with therapy. Is this level of engagement typical for pediatric patients or for patients with obesity?
So typically, they are not great compliers, those with obesity, and when you have type 2 and obesity, the compliance also, like the engagement decreases. Is this typical? I am not sure if this is like the average numbers for like, oh, most of the patients who have type 2 have this level of compliance. I wouldn't know that number.
Okay, great, thank you. And that's all the questions we have in the queue.
Great, so we'll just wrap up here. I just want to say thank you again to all of our speakers and all the journalists that took the time to join us both in the room and online. As a reminder, the recordings will be available on our website and YouTube channel, so we're happy to share those with anyone. And if you have any questions at all or would like to set up an interview with one of our presenters, please contact Jenny or I at media@endocrine.org. Thanks, everyone. Have a great rest of your day.